There's no financial incentive to make people healthy. Nobody gets paid more to keep somebody healthy or even equal.
So what worries you more? Because AI can get things occasionally wrong. And then as humans, sometimes there is a sense of fatigue and we stop noticing what went wrong.
There's two things you have to have, and it's coming across now, governance of AI. What is your use case? Who's overseeing it? At this point where we are with AI, I would never want it to ever deny care.
I firmly believe that our cost and opportunity for that 5.3 trillion is sitting inside that workflows.
That's not seen. I'm not saying, woe is me, but the administrative burden is equally high on both sides, and that's a waste of money. It's not improving the quality of care. It's not improving our trust in the system. And so it's a lose-lose for both sides. This is not working well. It's not cost effective, and it's not improving health outcomes. So let's get this fixed.
Few roles in healthcare sit inside more tension than a chief medical officer of a health plan. And that's what makes Dr. Soot's vantage point so interesting. As a CMO, she sits at the intersection of medical policy, insurance, operations, and economics of care. And that's exactly where some of the hardest trade-offs are being made today. Laurel, welcome. Excited to have you join us today.
Thank you so much. I really appreciate the opportunity.
So let's get started with something fairly simple. For people who don't know healthcare and don't sit inside the sort of four walls, what does a healthcare chief medical officer do in a health plan?
Yeah, it's a great question. I think where we sit is that intersection of what's clinically appropriate, meaning what is good quality medical care that your insurance is going to pay for. You then can add all things like clinical strategy, different places to get the care, different types of care, but ultimately it's ensuring that the members who are insured by the health insurance company are receiving high quality standard of care, and that is not being mitigated by other strategies such as cost or access.
And just to that point, in the marketplace, health plans are being known to be an organization that say no a lot. And at the same time, they're supposed to be driving, to your point, affordability, accessibility, and so forth. So how do you explain that tension to the regular consumer in the marketplace today?
Yeah, it's really hard because I think for the regular consumer, they're looking at it, and they should, as an individual. This is me trying to obtain care from my doctors. As the chief medical officer, as health insurance officer, this is truly population health management under a certain budget and a premium dollar. And that's what actually really interested me in this is we have a set amount of finances, and how do we ensure that we're allowing our members to get high quality care, but within the confines of true financial restrictions.
And then, so take us before the titles, everything. How did Laurel got to where she is today? Maybe the medicine and the whole thing.
Yeah. So my father was a surgeon. I grew up with watching that general surgeon lifestyle, and I was absolutely 100% convinced I was not going to be a surgeon. I did end up being very, very interested in biology, human anatomy. Thought I would go get my PhD in biology, but then really started to realize I really enjoyed learning about people and the anatomy, and cellular biology, although interesting, wasn't as interesting as people and caring for people. And I really did want to make a difference. I think that's always been there, and be able to communicate with people in times of need. So putting all those pieces together led to medical school. I really tried hard to like anything else but surgery, knowing the lifestyle. But surgery to me was absolutely fascinating. Being in the operating room, being able to make immediate changes. So that's what really led me to surgery. And I did in practice, when I was in clinical practice for 16 years, acute care general surgery was coming into the forefront. I was trained in general surgery, but did a lot of breast cancer surgery as well.
So if I met a 15-year-old Laurel, what would surprise me the most?
Yeah. This, I think, not that I became a physician and not that I became a surgeon. I will say the fact that I ended up in Portland, Oregon, I was definitely going to believe somewhere sunny, warm. Yeah, I thought about this question, and truly, I was on this trajectory. I just came back from a high school reunion. No one was really surprised that this is where I ended up from a career standpoint. But where I ended up, they said, "I thought you went to Southern California. What happened?" So I think
Yeah,
that's always a surprise.
it is. I think it's hard to say, where life takes you. I have friends who were practicing docs and then they become the researchers. So, I think it sort of goes its own way, I guess.
Yeah.
Tell me about something you touched on early on in your opening was as a doc, you are trained to take care of a patient. And today, as a CMO, you're supposed to take care of thousands, maybe even millions of lives. How do you make decisions based on what you can see today versus what you expect to see over the next several years?
Yeah. So I think there's a couple of things, and that's where before I became the chief medical officer, the role in the insurance company was the chair of medical policy. And I found that very interesting. It's very, very data driven, very evidence based, high quality medicine. And so the decisions truly are based on two things. And I think that's where a lot of the communication breakdown occurs with people that fail to understand, even physicians fail to understand. We have two things that determine what and when we're going to pay for something. One is a benefit, meaning that the employer has chosen to cover this or not cover it, regardless of whether it's medically necessary or not. Then there are what we call medically necessary services, and those are all proven by medical policy. So we have policies that can say, yes, we cover this, it's the standard of care. We know what it costs, that's okay. Cost is always the last, it's not the first. And so it's really patient selection criteria. The policies are very clear on what the evidence in the literature shows. So I'd say I think people would be surprised at how evidence based, literature based, society based, meaning the surgical societies, the nephrology societies, so that specialty physician society, we are looking very, very closely at what they're recommending in regards to treatment.
Tell me something about the world of GLP. I was speaking to a COO of a big health plan on the Eastern Seaboard recently, and he was talking about how much it has fundamentally changed the cost economics, how they price their product, how they sell it, the premium, how do they manage those members, because it is not just about either a weight loss or, you know, HbA1c management. But just curious, how are you looking at GLP peptides, essentially creating a significant burden on the cost side?
Yeah, I would have to say we were really on the forefront of being able to address that. And it was because I was very interested in it. From my training in general surgery, I was doing bariatric surgery. So when I saw the GLPs coming through, and coverage of bariatric surgery had a laundry list of things that you would have to kind of go through and manage. And a lot of that is the lifestyle. So if somebody is going to have bariatric surgery, can they continue the lifestyle management, meaning the exercise and the diet, and knowing what that cost was? Then, when we saw the GLPs come forward, I got in front of our chief medical officer at that time and I said, we're going to need to have a forward facing policy on this because this is going to be an onslaught given the obesity problem in the United States. 30 to 35% of people have a BMI in which they would qualify for weight loss. The data at that time was not there for the weight loss portion in regards to longevity. So, yes, you can lose weight, but do you keep it off to the point that you will have decreased heart disease, decreased kidney disease? Then what happened is that the GLP-1s were first became, because of the evidence, first line therapy for type 2 diabetes. And that's when I went to, at that point, I was the chief medical officer, went to our actuaries, went to our chief finance officer, and I said, we are going to have to cover GLP-1s for type 2 diabetes. It's clear. There's no type of step therapy. This is what we're going to have to do. The issue then is the one that's challenging for the United States as opposed to other countries, and that's the price and the price point for the GLP-1s in a capitalistic society in which you can charge significantly more for it than you would if you were obtaining the medication in Europe or Canada. And so that's where the economics really plays out. And I think that's where I've seen the most tension. We can say what's right to do from a clinical standpoint. We don't have a lot of levers on what the company's going to come out as the price point for that. And that's really the issue.
Say more on this issue of medication. I've been studying it for last a year or so now, Laurel. And then especially the seniors population, the number of meds they are on, the number of physicians they see, the number of opaqueness between the physicians in terms of what they are prescribing. And there's this sense of that there is almost never de-prescribing. And then the cost gets added on, the clinical issues gets added on. There's a medication risk safety issues and so forth. So how are you tackling with medication, especially in the seniors population?
Yeah, so we saw that. And I think it's where physicians become very specialty based. They don't know what somebody else has done. I think also when a patient gets hospitalized, it used to be that the primary care doc would come in and make rounds in the hospital. They don't do that anymore. They haven't for years. So then they have a hospitalist who's putting on, changing. And we saw medication. Initially, we saw, I would say, in a way, medication errors or the failure to notify the physician that we've changed a dosage or a frequency or added a medicine. So we started with that, and we have a very robust pharmacy department at Providence Health Plan that I love working with these pharmacists. They're brilliant. They're PharmDs. Many of them have worked in the hospital before. We have our own pharmacy benefit manager, so meaning that they really see this and know this. So we developed our own medication management team. And that is really what they do is when these meds come in between our pharmacist and the pharmacist at the pharmacy where the physician, where the patient is picking up their medications, they work together to say, what are we missing? What is needed? And then if we see duplicate or interesting frequencies, we will then reach out to the physician that ordered that and say, is this what we wanted? Are we sure? We also know and started tracking because of the cost. We were really concerned that some of our most vulnerable population, which is the Medicare, the Medicaid on unlimited budgets, were not filling the medications. So it's one thing to prescribe one. It's a whole nother, did they actually pick it up? And are they taking it? And that's a big gap that people weren't realizing from a cost standpoint, that many of our seniors are not picking up their medications because of the cost. So then we worked with them on that. We worked with the actual pharmaceutical companies to be able to obtain it for them for a lower cost. So there's a lot of things that you can get into, but that's really critical. If you want to keep your patient population healthy, you need to be taking the medications they were prescribed appropriately and accurately. So I'd say the bigger issue was not taking them at all rather than too many because of that cost.
Something funny, it reminds me when you just said that. So it's almost like a CMO of a health plan is like an air traffic controller, especially in the context of medication where you have all these meds, even for a single patient or 500,000 lives, no matter what, are flying around. And you need to be able to create a context between those meds, their fills, their procedure, providers, adherence gaps, and so forth. It's just fascinating of how much. There's something I've been thinking about that is medication or lack of it is the earliest and most actionable indicator of a clinical deterioration.
Yeah, it really can be because you have to pair that diagnosis with the medication, and you can do that. And so you can start to see all sorts of issues coming up, newly prescribed antihypertensive or lipid medication, cholesterol medication. That person's at risk for heart disease. Um, Diuretics, what's going on with their kidney or their heart or congestive heart failure. Antibiotics, significant antibiotics that are escalating, are they at risk for sepsis, infection? So absolutely. And so you add the diagnosis that went on to the medication, and then you can start to intervene. And we've been doing some of that, especially that's readmission reduction, as well as somebody gets admitted to the hospital, new medications, making sure that they fill their medications, they understand why they have a new medication, that they have their follow-up appointments. And that's where our care management, so we have a whole care management team of nurses who reach out to those patients when they've been discharged to the hospital to ensure that they follow up with these new prescriptions.
So, as a CMO, you are accountable for economics of care. So, say tomorrow, if I were to give you $1 million, and the only condition we put in that is somehow make healthcare more measurably better, where would you invest first, Laurel?
I'd have to say need maybe 100 million. A million doesn't go very far these days, unfortunately. And I think that's what people don't realize too. And I'll answer your question. But a part of my role too is reviewing when claims come through. So one hospitalization over $1 million. You think, what? Yeah, it's over $1 million. And I see those not infrequently. And some of that is looking, what was appropriate? Could this have been preventable? And so $1 million is a CAR T therapy, a chemotherapy, a trauma, a preemie pregnancy, stuff that we see and hear about, transplants. But if I was to say, if you had $1 million in a community, what can you do to improve healthcare? I would say at this point, having served on our American Heart Association board here in Portland, I would put it towards prevention or education of heart disease, which is still one of the number one killers of both men and women, and is incredibly preventable that people don't know, like easily preventable as opposed to some other things. And they had a whole campaign called Know Your Numbers, which is really getting in early. What's your blood pressure? What's your heart rate? What's your family history? And those are the kind of things that we can tag somebody and identify somebody early and really make a life-saving intervention that also decreases the cost of care. But so I would want to do something that was going to be really educating the public about their health and what they can do to really take control of it that isn't hard.
Let's expand that further because this is close to my heart. Why is it so difficult for parts of different healthcare ecosystem to really hone in on this preventative medicine? We all talk about it. Intuitively, we all know exactly what the value is. But each of the line of businesses, if you open it up and look at the share of expense they actually spend on this part, is dismally low. So I'm just curious, how do you sort of frame that?
Yeah, it's something it's honestly weighed on me for many years, and I thought, well, we'll see. And then in a health insurance company, I really see it. There's no financial incentive to make people healthy. And people are like, wait, there really is. There's not. In our current society as it stands, you will be financially better off as a hospital, as a physician, as a drug company, as a device manufacturer, as a health insurance broker, if if you have sick people. And everything in our country is driven by billing more for more things. Nobody gets paid more to keep somebody healthy or even equal. It takes a lot of time to talk to a patient about how they can make some lifestyle changes. What are some of the things they can do to make themselves healthier, to not need care? It's very easy to prescribe a medication. It's very easy to talk to the back pain patient about surgery rather than physical therapy, weight loss, activity, all of those things, and that's where our society is. So I'd say it's unfortunate, but everything is absolutely driven to taking care of sick people, and we do that really well. Like our outcomes are very, very good, but we have no financial or societal incentive to keep people from getting sick,
I mean,
and
no,
that's
no, no
issue.
wonder, we talk about Best Buy and Walmart and Coke. They probably are more consumer centric than healthcare is patient centric. So,
Yeah.
what's one thing that you would recommend that health plans start to do to tomorrow morning to be that member centric beyond what they already are doing today?
Um, where I think some of it is really highlighting where the issue is and what that is, and trying to engage with the membership at a different level. Access to good primary care physicians timely is really hard in this country, and America's so huge, and then we have rural, we have urban, we have metropolitan areas, and our rural areas are really, really struggling to even have a physician or have a caregiver. And again, those physicians, even if they see, need to charge to see people and to charge more and do more things. So procedures will pay them more than seeing a person and talking to them. And that was the whole basis behind value-based care and some of these initiatives that came up to really try to pay physicians to keep a group healthy, as opposed to pay for them for being sick. And for lots of different reasons, it's just been really, really challenging in the US to do that.
Yeah, one thing I'm seeing is the VBC is it becoming more of a manage the metrics that matters. It can be utilization, cost, safety, and whatnot. But is it really truly about improving the fundamental cost economics of this country? Because I think I was reading an article. We're already at 5.3 trillion. I mean, that's the third largest economy in the world. I mean, that's
And
just astounding.
it's astounding. And I think at a very high level, we have to get real about even high quality, good preventive care is going to be much more expensive than it is in Canada or Australia or Singapore. Why? Because the care that is being provided, GLPs are a great example, is too expensive. No one can afford the cost of goods and services anymore. And the cost of the goods, the appropriate utilization of the cost of the goods is too high.
Is this about there's a natural friction that we have created how the system is organized today, right? Where there's somebody's managing the medical benefit, there's a pharmacy benefit, there's lots of intermediaries of how the employers buy and sell sort of stuff. So if you were to think of that, friction lines between the LOBs, what's one thing that you will remove today just to make a sort of biggest cost impact?
Uh, that's it's a it's a big question. There is not alignment in this country on what we think is an appropriate amount of money to spend to provide high quality health care for our citizens. And we still don't know if it's a privilege or a right. And we also have not figured out what's public health versus medical health. And there is this gray line, but I've seen it swirl so much, especially in my own state with our Medicaid population and some things that came through of what we as a healthcare insurance company were to pay for. A great example, and this isn't bad, but it just shows there, it was refrigerators and air conditioners for medication. And we can obviously say if somebody, is in a heat area and it will affect their health. But at what point does your health insurance company pay for your air conditioner and a refrigerator versus not? And that's just a really very tangible example of we have not figured that out in the United States. And other countries have. Now they're smaller, they're more homogeneous population, but we've got to figure out what's a public health service, what is a medical service that is covered by your medical insurance benefit, and then what is going to be the cost of the good. And there's some great stuff out there. ICER has some really, really fascinating, we would say it costs this much, it should cost this much to improve a quality of care. And they'll price drugs, they'll price devices. We don't follow that in the United States, but the UK follows it, Australia follows it, Singapore follows it, and they'll just say, well, this is too expensive. We can't pay for it. Lower your price, and then we'll talk about it.
Tell me about in healthcare, we love introducing stuff. There are new meds, there are new AI tooling, there's new devices, and all combinations of all those three things. So is this about where you truly look at sort of first principles philosophy and say, you know what, we're going to catch that rocket before it gets to the ground? And then by doing that, we'll probably save around $60, $100 million per rocket launch. And here is how we'll get to that. So I'm just curious, is our struggle where we are just digitalizing or digitizing the complexity that continues to exist and expands versus truly saying, hey, we need to eliminate and delete certain parts of what we do today. And only then that 5.3 trillion will look a little bit differently over the next several years, if not decades.
Yeah. And I think the other thing we need to do with that is, and what I used to tell my own patients when it's clinical, they would come up, oh, this new thing, this new thing. I said, medicine is different than the next version of your iPhone or the next upgrade of your software. Those should run better than the last one you had, or your new car. That really should be better in many ways than the last one you had. Medical devices and drugs are not the same. They just inherently are not. And we have to be okay and really understand what is the standard of care, meaning evidence proven, you will get better. We can measure that. Even putting the cost aside, are you going to be healthier with this intervention, with this device being put in or this drug than the one that we currently have for this treatment? And again, cost aside. We don't like to do that in the United States. The device manufacturers and drug manufacturers don't like us to do that either. The other thing we do is everybody needs one. So it's like there's something called patient selection criteria in which the evidence shows if you have, like these 3 or 4 variables, then this is the thing that you need. And that's a lot of what medical policy is. And people say, oh, they denied this care. And it's like, well, because the evidence showed you have to have these 3 things in order for this to work. And the evidence doesn't show if you don't have those 3 things that this is going to be any better than the standard of care. And that's really hard. I think a lot of people in the United States were not educated in, and it's not that they're non-intelligent, they just didn't learn critical analysis and critical skill and really analytical skill thinking and what's science based, what's an hypothesis, what is an show, and social media and influencers and all those things have not made it any better. And so I do think that that's an issue.
Let's start there. You talked about evidence of care and medicine, an important, sort of source of truth, if you will. Is AI helping in creating a more consistency, more usability of that in your world today?
I think if it's used appropriately, it can. There's a new tool, Open Evidence AI, that you can use as a physician. I have to have a physician's license too. And it collates all the scientific data together. and kind of gives you a this and this and gives you quick references. It makes it faster. It makes it less time, less time consuming to go gather those references yourself and review them. But you have to look at them too. I would not want AI at this point making a clinical determination because AI is just a database. It learns, and who's trained it and what is it. So I'm always cautious about the database that the AI was trained on and if that's appropriate or not for the question that you're asking.
So what worries you more? Because AI can get things occasionally wrong, right? And then as humans, sometimes there is a sense of fatigue, and we stop noticing what went wrong. So, as a health plan, you know, and a medical executive, what worries you more? How do we deal with that?
Yeah, I think there's two things you have to have, and it's coming across now, governance of AI. What is your use case, and who's overseeing it? Especially in the health insurance world where there's approvals and denials, AI can be incredibly helpful. We're learning in culling through large amounts of information that would actually take a person, a nurse, going through 300 pages of chart notes to find the things that you need, so like an MRI and labs and physical therapy, to say, is back pain, person with back pain, did they get the appropriate workup and treatment for this surgery? And that can be really helpful because it will go through really quickly and then flag where that information is. At this point where we are with AI, I would never want it to ever deny care. And I'm hesitant on approval unless something is really very algorithmic. Check the boxes, everything is there. And that depends on the disease state and what you're looking at. But at this point, it hallucinates, so it comes up with stuff. It doesn't tell you, I don't know. I don't have enough information. Now, I have seen some models that they're working on that it would do that and it would be trained. So I think, where are we going to be in 3 to 5 years? It's going to be interesting. But right now, I would never have it make any type of medical necessity determination for a patient.
Let's expand on that. So let's say fast forward 5 years from now, to your point, the frontier labs will get better, models will get better. How do we create context and hallucination management, and guardrails will probably get better. So say all of this does reduce, enable us to have some reduction in our admin costs today. Will we find new places to spend money, or will we actually make it more affordable?
I think we'll find new places to spend money. I mean, because so AI, the other issue with AI, where I think we can make things better, is in new operations. So right now we have a very antiquated workflow that when you think about it, I went back and looked at we were writing chart notes like we write into Epic or when a doctor sees a patient, the way that we format that chart note has not changed since the 1960s. And even before then, it was all the same. So when you think that one-on-one, I'm going to talk to you, we're going to find out, and we're going to make a decision. And then we've added all this additional stuff to the physician's workflow. And then we give it to the insurance company and they've got to go through all this additional stuff. We have really made a very, very complex operational process. If you just plug AI into things to make it faster, you're still going to have a very complex, very opaque process that people don't understand and is really, really frustrating. We're going to have to change workflow processes, include AI. And then I do think where the cost of care can come in is when we start looking at that quality of care. When we start looking at predictive analytics, it's going to be really, really good at raising flags and pattern. It's really good at pattern recognition. So how do you prevent an admission? How do you prevent somebody from having a heart attack and 2 stents put in and complications and cardiac surgery? It's because you saw the signs earlier and you intervened earlier. So if AI can help us, you've got 2,000 patients on your panel. You don't know which one is going to really, really needs that mammogram and which one is probably okay that they missed it. It will be able to flag that. And we used to see that as physicians all the time in the emergency room. You take that history, you look at it, and you'd say, we knew that this was going to be the outcome. We knew that this could happen, but we didn't intervene sooner because it was just one patient and these different data points that somebody hadn't put together. So that's where I think AI could be really helpful, both in quality and cost of care.
So say we got Laurel that $100 million she was talking about today, 2026, August, and you can set up a health plan or healthcare system the way you want it, maybe AI native first. What would you eliminate from what is being done today in that?
I think, and I don't know. I hope I don't get in too much of a hot water here. What I had no idea that existed was the middle layer between an employer or a person even obtaining insurance. And those are our brokers, and the fees and the management and the amount of money that is being spent by employers to their brokers to get the insurance for their members, the amount of time the health insurance company works with those brokers to kind of sell themselves as this is the health insurance company that you want to give to that employer. So there's a whole underlie throughout this country of sales, brokers, deals to get these members that I was absolutely not aware of. I would design a health plan in which we could get rid of the broker's fees, the taxes, all of that, to ensure that we're just providing appropriate care and paying for it. And that the physicians who are contracted and the hospitals and the facilities that are contracted with that insurance company understand what that contracted rate is, and that everybody is in agreement. There's a lot that's underneath that I didn't even know about until I got into this job.
You're right on. I think there is, 5.3 trillion is enough to find something in few hundreds of billion, if not more.
There's big money in healthcare insurance and healthcare dollars, and I think we have to really understand. First of all, you have to understand where all of it is being spent. We're really good at pointing blame at other people. Oh, the doctors are, it costs too much. Oh, the hospitals. Oh, the insurance companies took all the money and they didn't give it to us. We have to get away from the blame. Open it up. Be very transparent. Here's where every dollar went. Are we okay with that? Or do we think, and this is why the cost of the goods and the services is as high as it is, and are we okay with that? Or where do we say, you know what, I just don't think that's worth the return on the investment.
So as a surgeon who's accountable for the economics of care, imagine you're in a situation where your Excel sheet is telling you something else and your clinical intuition is telling you something else. How do you make those decisions, Laurel?
Yeah, well, that's actually one of the roles of the chief medical officer. When somebody comes and says, this costs too much money, we're not going to do this, or we recommend you stop paying for this service, or you deny it, or you bundle it, I always go to the evidence. I always have, what does the literature say about this? What are in a surgical case, what are the surgical societies saying about this intervention? And I've actually, even in the last few months, been on that end where I said, no, this is something we're going to pay for. I ethically cannot say no to this cost of care because it is medically necessary. But then you can go to your contracting team. And that's, again, kind of this whole thing. Here's the utilization we're going to see for this service. Now go contract for the lowest unit cost you can get for that drug, the lab, the procedure, the whatever it is. And that, again, is the whole world that people don't see either, is that contract negotiation for the unit cost. When you say, I'm going to utilize this service for these people, and then that's what your actuaries need to price the premium. So number one for me as a physician is standard of care. Is this the standard of care? Is this appropriate medically necessary care? I'm going to say yes. We're going to pay for that. And then the question becomes how, or what's the best way? And how many of our people are going to need that care?
That's fascinating. So as you've grown from, from your role to today, Laurel, are there things that you had to unlearn?
Yes, in that it's bigger than the patient in front of you. I think that when you are a surgeon taking care of one patient with one family and having those discussions, it is one-on-one. I had to start thinking about that, and we get some really unique and kind of tearjerker cases, things that come in, and you want to say yes. Sometimes you're like, we can't. And I'd say the one part you say, well, what would that be? I had to unlearn clinical trials. And I was part of an academic institution and trained in an academic institution, had done my own, research with people. And I had to learn that the health insurance premium is not built to sustain clinical trials. And that was really hard, honestly, to see these people and say, we can't, there's different ways to pay for it, but this is parts of the standard of care and this part's part of the trial, and we're not going to pay for that part. That was hard.
Do the other executives in healthcare, C-suite, get this?
Yes, but they come at it from a different angle. I think that's why I think it's so important for physicians, surgeons to be in leadership positions, to sit at that table, because we understand the workflow. They don't understand the workflow. And that's not, it's just because the workflow is so complex. There's a reason why you do 4 years of medical school and 6 years of surgical residency, and then really aren't really ready to practice independently and feel just confident about your decision making until you're a good 3 years out. So that's 13 years of really in-depth training and knowledge, and you can't just give that to somebody and have them understand. So it's always been fascinating, and I'm glad I'm at the table when someone will come with an idea that thinks great. I'm like, don't want to burst your bubble, but that's not how we practice medicine. That's not going to get you the outcome. And they often come with a solution to a problem that hasn't been well defined, or a solution. And he's like, what's the problem you're trying to solve? And then they'll tell you, like, let's walk through this workflow and see why this solution is probably not going to be the best one or get you the outcome that you wanted. So critical to have physicians at leadership.
I was speaking to this a major pharma CEO. He's a surgeon as well. And we were talking about AI. And one thing he shared, which was fascinating, was and this is like a $45 billion, pharma shop. So it's pretty large. The way he's thinking of AI is very simply that look at the most mundane, routine workflows in his organization, R&D, commercial, so forth. Look at where humans spend most time and look at what parts of those human effort can be eliminated. Do it 1 time, 10 times, 50 times, 100 times. You got your AI strategy ready. He said, and what it does is it grounds into the organization versus becoming this another case of, hey, we have something, tell us what to solve for, right? I think so.
Exactly. You have to know what your problem is, then what's going to be your solution, and is AI going to be there? I do think that AI is going to be very, very good for areas where there is human error, in which a computer algorithm is much better. So transcribing numbers from one Excel sheet to another, or programming and data validation. So where manual work is not requiring critical thinking, it is truly manual work. So we say packing the boxes. How do we get AI to pack the boxes so that then we can oversee with critical thinking? Are the boxes being packed correctly? Are they going where we wanted them to? We had to change in the order. Where does it? Where does this go now? The machine broke. We can't pack the boxes. Like, okay, so now what are we going to do? That's where you need people, because more and more is coming up that AI is not programmed to do that. And there's some kind of funny stuff out there. There's some good stuff out there. There's like, oh yeah, I didn't think. And so program it to pack the boxes routinely. Have the person overseeing when something doesn't go right and to critically think. So that's absolutely what I would say. We don't. That's its role right now.
Let me ask you something more strategic. So, today's 2026, say 3, 5, maybe even 10 years from now, what would a health plan of a future will look like?
I do think they will be more digitally savvy, because people will continue to have technology. But you have to also create a second path in which it's not a disparity if you don't have the technology or don't want to use it. So there's that dual. And then I think it's going to be much more interactive with the patient rather than passive. And that's where I think we get that buy-in. So we're starting to see it in little areas where somebody has a wearable device and it downloads and the data goes into an AI computer system, then flags it for the physician to say, we see so and so, we're on a lifestyle modification program with diet and exercise. They only took 3,000 steps for the last 4 days. Should we call them? Should we find out what's going on? Let's see. So you can start to get pretty proactive. What is their blood pressure reading? It takes it. It's got it. We're not quite there yet where a watch can take your blood pressure. We're getting better. So I think it's more real time identifying those critical things that we know need intervention sooner than the patient knows, sooner than the physician knows or can get them in. And then you triage who gets in sooner, who gets in more quickly. So I think that digital kind of front door is real, but it needs to not be flashy. It needs to really be really thought out of how that goes, and how we engage people with their health instead of being passive. I think is really, really important. And understanding and being able to advocate for themselves, which is that education piece. Those are the two things I'd want to say. And then the physicians are working in tandem with the hospital facilities, and in my world, my ideal world, with the insurance companies, because they understand, because they're communicated that there's a trust now where there is no trust because there's a lack of understanding, and how we communicate, even using simple language like benefits and denials and EOBs and COBs. People don't know what that means. And if we could really, really have physicians and members and the health insurance and the hospitals all in alignment that yes, we are paying for medically necessary services. How do we get this done, and how do we get you healthy and keep you healthy? That would be amazing.
Well said, Laurel. Well said. So, so say tomorrow, your peer groups, the health plans, CMOs are listening to this. What's one thing you would suggest they ask their leadership team about AI that they're not asking today?
I would say, have we identified, again, I'm going to get into have we identified problems that we think AI is a solution for us? And how are we managing that and looking at it? Because I see two, and the reason I say that is because I see two things. One is we don't want to do that, like too much money. We don't have time to have that top technology and implement it. So it's a total no, or governance and safety and HIPAA. or it's a yes and they just throw it in, like I said, into a workflow and haven't trained their staff and their people. So pilots work, and then you try to put it enterprise wide, and it just bogs down. And so I would say it has to be very thoughtful. Get the key people that this AI workflow is going to impact their workflow, have them help you design. What does this new state look like? Pick a real, pick a complex operation that nobody's happy with, that's struggling. Claim timely claims payment if you want to make it that. And don't take everything, but take one thing, get everybody in that room that does that, walk that workflow process out, and then say, how do we make AI make this faster? Not like, ooh, we just made this part faster, now it's going to bottleneck here. Do we have is there a solution out there that can do this for us faster, better, more efficient, less costly, better outcomes?
No,
That's
I
what I
love
would.
it. I tell you why, because I think I firmly believe that our cost and opportunity for that whatever 5.3 trillion is sitting inside that workflows. You fix portions of that enough across larger portion of where we run healthcare today, we'll probably have some savings, if not more.
100%. The administrative costs on both ends, and that's what we hear about a lot. And I don't blame them, providers, facilities, the burden of PA, the burden of prior auth, all this time. The burden, and the health insurance companies have been fairly quiet about, the burden on our side is huge as well. The amount of people that we have employed to try to process prior auths, medical benefits, denials, reconsideration, do all that over and over and do it right and do it from a regulatory standpoint, because there are so many audits that come through. And no, that's the part that's not seen. I'm not saying, woe is me, but the administrative burden is equally high on both sides, and that's a waste of money. It's not improving the quality of care. It's not improving our trust in the system. And so it's a lose-lose for both sides. And until we really say, yeah, this is a lose-lose, how are we going to change it? Then we're going to keep having these discussions and kind of pointing blame at each other, rather than saying, let's roll up our sleeves, let's get in the room, and let's get this figured out, because this is not working. I think we can all agree, what's the problem? This is not working well. It's not cost effective, and it's not improving health outcomes. So let's get this fixed.
So on that note, so let's say if I put Laurel in a time machine, and you have two options, there are two buttons on that machine. One can take you back in time, the other one in future. Where would you go and why?
Oh, from a medical standpoint or a personal
Personal,
standpoint?
anything.
Ah, that's interesting. Uh, so I was an art history minor, so some of that artistry of like the Michelangelo, or going back into the Monets, and those things would be really interesting. But I think the future um, is so fascinating, because we do have this opportunity as a global economy now, across the world. We're not so limited to our community or our cities, that I would like to go into the future, and I would hope that we'd improved things instead of made things worse. But people are people. So I guess I know what the past is. I would like to jump into the future and see if we were really able to rally around some key values that we value. So healthcare, education, do we value it? And then how do we show that value for our citizens of the country and for the world?
And who knows, you might find yourself either at Moon or Mars.
Exactly. Never know. That I would love to go out in space. Yeah, that would be amazing.
All right, cheers to that. All right, now the fun time. So let's get to the lightning round. This is my favorite. So there are 10 questions. You can probably take a word or two uh, to respond to this. So, game for it?
I'm ready.
All right. A decision you would never delegate to an algorithm.
Never I'm sorry, dedicate to a what?
Never delegate to an algorithm.
Oh, delegate? Oh, the decision of whether you should have an operation or not. Surgical operation.
One healthcare metric you would retire tomorrow morning.
Sorry, I'm not going fast on this
That's
one.
okay. Take your time.
Healthcare metric. If you're satisfied with the care that you received from your physician and you've asked the health insurance plan to have that as one of their quality metrics, which they currently have, we don't have much control for physicians. So I would don't ask a healthcare insurance to improve how their patients are doing with the quality of care of their physicians.
Cool. Good one. So, boardroom or bedside, where did you learn most about your leadership?
Bedside.
One non healthcare industry that healthcare should study more closely.
Continue with the aviation industry and how they manage.
Interesting. And if you could shadow one person outside healthcare for a day, who would that be?
Mm, that be. I know it's such a pause.
You can go back in time.
I can go back in time. I would love to have been at the time when they developed the microscope and they saw everything that was there that they didn't know was there. I think that would have been amazing because there's a whole world, either the microscope or the telescope, because it takes something that's so opaque and you think you know what is there, and you look under and there's this whole other world. There's literally another world. So
That's deep. So, speed or perfection?
I'm a little bit of both as a surgeon. Make decisions quickly. Um, I would say quality is number one. So, but you don't want to say perfect. So I can't pick both because as a surgeon, we're trained. It's don't go too quick, but man, don't if you wait to be perfect, it's never going to happen, and that patient needs an operation.
So, one non medical skill you're oddly proud of.
I'm a really good downhill skier. People would
Hmm.
not know that, but I grew up I did a little ski racing, and I'm a good downhill skier.
All right. One word your team would use for you.
Calm, compassionate, calm.
Love that. All right. Finish the sentence. The best leaders I know are unusually good at.
Listening, actively listening.
Love that. Love that. Thank you. Thank you, Laurel. This was deep, insightful, honest, and grounded.
Thank you. Thank you for the opportunity. I truly appreciate it.
Absolutely. I think I'm taking back a couple of things. One is, I think the place you started where, define the problem, work on first principles, right? Solve what it matters, right? And then whatever tools are available to you, use them, but don't make them the solution itself.
Yeah. And some of that's really the surgical training. You have to know, it's that differential diagnosis and whether or not you're going to take somebody to the operating room. And when you operate, what is your plan? You can't just go in there and be like, well, we're just going to look around. Bad idea. And so I was just honed in for 6 years. What's the problem? What is the solution? Surgery is always the last option, never first, because of the risk entailed with doing an operation. And so when you come to the decision to do an operation, you're very clear and you better know what you're doing. Like, so now you've decided to operate. What procedure are you doing? How are you going to approach it? What are the complications that the patient has had or prior surgeries they've had that is going to make that approach challenging? So it's taking that surgical mindset to other problems and using that, and that has kept me, I think, grounded. It's kept me safe, and it's kept me making good decisions because you have to know the problem you're going to solve. Then you come up with the solution. not backwards. And that's where I see things go wrong.
Super, Laurel. Awesome to have you.
Thank you.
Thanks for everything.
Yep. Appreciate
Cheers.
it.